This video gives practical guidance for mentors in clinical practice when undertaking the portfolio-based discussion. The portfolio-based discussion forms part of the assessment in clinical practice for all Staffordshire University student midwives. The examples shown in this video are of the assessment of a third-year student midwife, which is at level 6. You may need to adjust the type of questions and the grading according to the stage of training of your student. And I've seen that you've written a reflection about the physiological third stage.
Yeah.
Is that right?
Yeah.
Can you explain to me what the third stage of labour is?
Oh, it's when the placenta needs to be delivered.
Okay. Can you expand a little bit more on that?
Well, sometimes there's like membranes as well. So you need to make sure that that all comes out, and there can be bleeding as well.
Yeah. Okay. So what sort of thing would you do as a midwife in the third stage? Can you?
Well, you've got to deliver the placenta.
Okay.
I suppose you've got to introduce baby to mum and sort of decide how she's feeding, things like that. So she might be breastfeeding, so you might have to help with that. And you don't want to do anything too quickly with the placenta. So you'd be you sort of pull on the cord to but you'd have to make sure you didn't pull the uterus out as well.
Okay.
So you guard with your hand here,
Okay.
the tummy. So pull a bit on the cord and see if there's anything coming.
Okay.
Do you know what I mean?
Yeah, yeah. Can you explain some of the physiology behind those management pieces?
Well, sort of when the baby's born, there's contractions which will have been helping the uterus to contract, and probably cause separation of the placenta from the wall, hopefully. So that's why when you pull on the cord, you're hoping that that's happened, and sorry, my mind's gone a bit blank.
Okay. So you particularly wrote about physiological third stage. So what's that, and what are the other options of delivering the placenta?
Okay, so physiological is not using drugs to deliver the placenta.
Okay.
And it can take longer than using drugs. So you're sort of going along with nature.
Okay. So would you still pull on the cord?
Well, not all the time.
Okay.
Perhaps if it wasn't coming after a while. I mean, it does take longer, that I've read, than the giving drugs. But I suppose perhaps if it didn't come in the end, you might want to give it a gentle tug.
Okay. Okay, I think we'll leave that question there. We'll move on to another part of your portfolio. Okay. I'd like to start by asking you to explain to me what is meant by the third stage of labour.
Okay, so the third stage of labour is from the birth of the baby, so the end of the second stage obviously, to delivery of placenta and membranes, and achieving like, hemostasis. So that means like no PPH, that type of thing.
Good, thank you. Okay, so you specifically spoke about physiological third stage. So what is that, and are there any other ways of managing the third stage as a midwife?
Yeah, you can give an injection of syntocinon or symptometrin, but NICE guidelines 2014 recommend just the syntocinon, so without the ergometrin. Sorry, I'm warbling on a bit now. So the physiological third stage is when no intervention is done by the healthcare professional in terms of giving an injection for delivery of the placenta, and it's going with the physiological process, of what would happen anyway, even if nobody was around.
So can you explain a little bit more about that, or the alternative methods?
Yeah, so what happens is with the birth of the baby, there's with the final contraction, there's a big contraction, and normally or hopefully that causes the placenta to separate and go into the lower part of the uterus, but sometimes that doesn't happen. But because of all the contractions, the uterus has the space in the uterus has diminished a lot, so it's smaller in there. So sometimes there can be like a blood that goes back into the intervillous spaces, like where the placenta's attached onto the uterine wall, and then there's like living ligatures, which are the oblique muscles of the uterine wall, I think, and they would act as living ligatures. They call it in a lot of the textbooks to clamp down on the blood vessels that supply the placenta, and that would help with the separation. So it like shears off the wall, and then because it's all got congested in the uterine wall because of the blood going back into the intervillous spaces, that would cause the placenta to detach as well, and then fold in on itself and drop, separate. And a way you would tell that by like being the midwife would be if the fundus like raised, you could feel that with your hand, and you could also see like the cord. You'd wait for, you'd see signs of separation perhaps as well, which would be like quite a trickle. Sometimes it can be quite a lot. I think the one I saw was quite a lot, and I was a bit worried, But having read the textbooks, it was like it said that can be normal, that it can be quite a bit of blood, and the cord lengthens as well. Whereas with active management, which is what the other, you either have physiological management or active management, you give an injection with the birth of the anterior shoulder, and then I think you still wait for the signs of separation, which I've described, and you might feel if there's separation. But then after a minute, because I think it says you have to wait a minute, you would try control cord traction, which is when you pull down on the cord, guarding the uterus.
So you said that you'd expect quite a bit of blood loss. What's a normal blood loss in the third stage of labour?
I think it's under like about 300, something like that.
can you tell me a little bit, first of all, about what the third stage of labour is?
Okay, so the third stage of labour is defined by NICE 2014 in their intrapartum care guidelines as being from the birth of the baby to the delivery of the placenta and membranes and hemostasis, so the control of bleeding. Excellent. From the placental side.
Good, thank you. And can you explain to me what is meant by physiological third stage? What does that involve?
Yeah, so it's as opposed to active first stage. Begley 2011 says it's no prophylactic uterotonic drugs, no cord clamping, and no control cord traction, and encouraging the woman to perhaps have a position that encourages gravity to work for the physiological mechanisms of the third stage to get them to work and do that in the best way, so you can have things like gravity or have the baby breastfeeding, because that releases oxytocin, which helps with the contractions and helps the placenta to become separated.
Good, okay. So just explain to me a little bit more about active third stage.
So active third stage, sorry to jump in there, as Begley, which was 2011, or the NICE guidelines 2014, is similar ways they describe it, it's the use of a prophylactic uterotonic drug, cord clamping and control cord traction. It's with the birth of the anterior shoulder of the baby, giving the drug intramuscularly into to the lady with her consent, obviously having asked her previously, discussed this all previously. So giving that, and then once the baby's born, waiting at least a minute, and that's per NICE guidelines, intrapartum guidelines 2014, but up to 5 minutes. And obviously if the lady wants it more than 5 minutes, but that's their recommendation. Then looking hopefully the signs of separation as well, which is blood trickling and lengthening of the cord. And rising of the fundus to show that the placenta is separated, and then using control cord traction. See, I'm doing it here. So you put your hand on the uterus to guard it, and that's to make sure that you don't get an inverted uterus, and gently pull down with traction down, and then follow the curve around as you're bringing the placenta out.
That's good. Yeah, very detailed. Okay, so what do you think is better?
Oh, it's difficult, that one, and I know midwives should base any healthcare practitioners should base their practice on the evidence. Mm-hmm. So I've been looking at the evidence, because initially I thought physiological, because the midwives I'm with are really great, and it's a maternity-led unit, so it's all very normal, and the ladies are low risk generally. So I initially thought physiological, and I read a lot of, like I keep mentioning Begley, but a lot of her work, and the Cochrane review by MacDonald and Middleton in 2009 are quite in favour of physiological. They sort of say that it reduces the risk of the infant getting jaundice, because the cord isn't clamped. And because the baby's left to get more of the HB going into it, so but then NICE, when it came out in 2014, said that it said actually that it was quite dangerous physiological. Well, it didn't say that, but you could take that from reading it, in that it recommended that active management was what midwives did, unless the woman wanted specifically different, and that was documented very carefully, that if the woman didn't want active management, then that was very carefully documented. But if she was But again, if she was low risk, she should be, yes, enabled to have physiological. But it wasn't very clear really, because it was like she should be enabled to have physiological management if that's her wish, but only if she's low risk. So, you know, and then I always thought, you know, from the code and from the midwives' rules, that you have to honour whatever the woman wishes. You know, it's about women-centred care. So even if she was high risk and she wanted physiological, it would still be the midwife's duty to do that, to enable her to have that. I suppose you'd have to put a risk plan into place, wouldn't you? So going back to your original question, I think the research gives pros and cons for both, really. But I think it's working with the woman on an individual basis.